Hello, I'm Chris Wagstaff from the School of Health and Population Sciences at the University of Birmingham.
And I'm Tarsem Singh Cooner from the Centre of Excellence in Interdisciplinary Mental Health, also at the University of Birmingham.
We're going to present today about developing communities of inquiry for blended learning in the context of interdisciplinary teaching and learning between mental health nurses and social workers. When this initiative ran in 2009, it was the second time it ran. We'll be reflecting on both the 2008 and 2009 iterations. The starting point for this initiative was that we were concerned about the lack of multidisciplinary training at qualification level in mental health training. Indeed, anecdotal evidence would suggest that even in first-year undergraduate work, separatist attitudes are apparent. We recognise that there is more at post-qualification level, but at which time separatist attitudes and identities may have become cemented. And thirdly, there were opportunities presented by the Centre of Excellence in Interdisciplinary Mental Health, being able to both fund the blended learning approach and also provide the teaching space. In particular, there is the provision of a large flat floor to encourage dialogue and group work. Also, the Centre provides a technologically rich environment for students to continue online work. Upon entrance, there is a welcoming open social space for mental health service users and carers. The overall aim of the initiative was to develop an interdisciplinary dialogue on improving service delivery of mental health care based on a community of inquiry model. Within that, the objectives were 1. To explore the distinctive roles and values that different members of the interdisciplinary team bring. 2. Explore the different theoretical perspectives with which mental distress could be understood. Then, in days 2 and 3, these were applied to working with self-harm and improving the experience of inpatient care. As regard the background of those involved, there were 3 academics involved in the 2009 initiative: Dr. Jerry Chu from the Institute of Applied Social Studies, Tarsem, and myself. There were 5 professionals involved: a clinical psychologist, an occupational therapist, a social worker from clinical practice, and a consultant psychiatrist. The 5th professional was someone who's a qualified nurse, a very active researcher, and a voice hearer. His contribution was on all 3 levels, hence the speech marks. There are 5 service users and carers. It should be noted that the service users and carers were involved in the design of the initiative from beginning to end, planning, implementing, and evaluating. From our service user and carers perspective, we feel this represents a fairly uniquely high level of service user and carer input. There are 4 groups of students in the 2009 initiative because after 2008 evaluation, the nursing students felt that the initiative would be more useful in their second year as opposed to their third. Therefore, for 1 year only, there were second and third year nursing students, undergraduate and postgraduate social work students. It is important that we talk about the structure of the initiative. To start with, there's preparatory work that was introduced 2 weeks before the face-to-face sessions. The nature of that preparatory work we dealt with in a few slides' time. Days 1 through 4 were spread across 2 weeks in January and February 2009. The morning of day 1 was a discussion of the roles different people play in the interdisciplinary team, and that included service users and carers as members of that interdisciplinary team. The afternoon of day 1 was an exercise that encouraged people to examine their personal and professional values and how these related to an evolving case scenario. Day 2 dealt with the different theoretical perspectives of which mental distress could be understood. Day 3 looked at working with self-harm, and within that, students were encouraged to examine what they believe self-harm to be. Day 4 focused on the implications of inpatient care, looking at how pre-admission, admission, and post-admission could be improved through greater collaborative working. For day 5, students were required to do an interdisciplinary group presentation. These were based on case scenarios that were unique to each group. Part of the community inquiry model is to encourage reflection and debate. To that end, day 5 was 3 weeks after day 4. It's important that we highlight at all stages that there was a large teaching presence, both from the academic staff and from the service users and carers. One point that we haven't made before was that the students were divided into 7 groups. Each group was facilitated by a service user or carer, and that service user or carer stayed with their group for all 5 days.
Thanks, Chris. We adopted a blended learning design to overcome some of the time and place barriers that have traditionally made interdisciplinary teaching and learning problematic within universities in the past. This blended learning approach was heavily influenced by the community of inquiry model. Garrison and Vaughan argue that an effective educational experience occurs when three elements, they call presences, are accommodated within a teaching and learning design. The first of these three is called social presence. In the development of our teaching design, we try to ensure that opportunities were built into the learning process that encouraged students to create an environment in which open communication to explore different discipline-based perspectives encouraged active discussion. This active discussion, we found, then led to group cohesion, in which the service users and carers were accepted as equal members of the group. The overall process led to the sharing of personal experiences about mental health service delivery that resulted in learning that had a profound personal effect upon all those taking part. The development of active learning and discussion did not just happen. The second presence, called cognitive presence, encouraged us to design activities that encouraged exploration, discussion and debate based on the learning objectives set for the module. This was achieved by following the guidance offered by this model and ensuring that there were ample opportunities to create 4 items to develop cognitive learning activities. These 4 items are a triggering event, so that discussion was at the heart of the learning design. For example, the videos we developed to explore the issues of mental distress acted as triggers rather than just as passive content delivery packages. Exploration. Because the trigger videos had attached questions, they encouraged group members to share their perspectives with each other. Integration. We created problem-based case studies that helped the students, with the aid of the service users and carers, to integrate their learning through a process of iterative planning and reflection. Resolution. By testing their proposed solutions to the problem-based case studies within their own group and peers, students were able to test the validity of their learning within a wider reflective interdisciplinary group. These steps ensured that students did not just passively sit in the same room, listening to a lecture, but rather engaged with the materials to develop their learning. The third presence, called teaching presence, enabled us to ensure that service users and carers, along with academics, were involved in setting the curriculum and methods. As academics, we chose carefully when to step in and facilitate the discussions that took place online and within the classroom to ensure that we did not take over the learning process. Our aim was to encourage the service users and carers to share their personal experiences of mental health services to develop learning. Other than face-to-face teaching situations, we did occasionally step in with direct instruction if online discussions were going off topic. In these cases, we gently steered the discussion back if required. Whilst not perfect, this model did help us to create a climate that supported learning through discourse and the selection of appropriate content that encouraged active and authentic learning to occur within a blended learning environment. This is the end of the first section of the presentation. Please move on to the second part.